Methodology program at McMaster. Let me introduce our next moderator. Fatima Sheikh is a PhD student in the Health Research Methodology program at McMaster University. You know she makes good decisions because Dr. Fox-Robichaud is her boss and her mentor. Her research aims to investigate the effects of social determinants of health on the incidence and outcomes of sepsis and develop knowledge of the effects of social determinants of health on healthcare to inform health policy. This is such important work. And she hopes that training in both research and as an educator will allow her to develop the skills and aptitudes to establish a program of research focused on equitable healthcare practices, specifically within critical care, right? To balance both the engagement, the research, and the education. Fatima, I'll leave up this slide while you introduce your panel, and then I will close it out.
Thank you so much, David, for the kind introduction. And yes, I'm very, very lucky to be supervised and mentored by Dr. Fox-Robichaud. And so I'm really pleased and quite excited to be moderating this panel on how to lead quality improvement initiatives. There's so much to learn, and we have an amazing lineup of panelists with us today. And so really quickly before we begin and I start to introduce our panelists, I'm just going to go over the structure of this session. I will start by introducing each of our fantastic panelists. They will spend about 5 or so minutes talking about their experience leading QI initiatives, what they've learned, the challenges, and anything else they'd like to share. And during this time, I would encourage all of you to think about and share any questions you might have. Once each of our panelists have had an opportunity to share some of their insights, we'll move into the Q&A portion of this session. And so with that, I'll jump right into introducing our panelists. Joining us today, we have Dr. Sean Townsend, Sybil Hoiss, Rick Bassett, and Dr. Halima Salisu-Kabara. Dr. Sean Townsend is Vice President of Quality and Safety at California Pacific Medical Center in San Francisco and a Clinical Associate Professor of Medicine at the University of California. Dr. Townsend is a nationally recognized leader in patient safety and quality improvement, a faculty member at the Institute for Healthcare Improvement for 20 years, and a founding leader of the Surviving Sepsis campaign. Presently, Dr. Townsend serves as a measure steward for the Center for Medicare and Medicaid Services First Sepsis Quality Measure, SEP1. Sybil Hoiss is the lead clinical initiatives and innovation at Critical Care BC and previously worked with the BC Sepsis Network as provincial quality lead within the Analytics and Strategic Initiatives team and other council initiatives. Prior to joining the council, Sybil was a clinical nurse specialist in critical care for Ontario Health, advancing nurse practice and building quality and efficiency across networks and practice areas, promoting regional and standardized approaches to care delivery. Through collaboration and fostering respectful relationships, Sybil actively seeks input from all partners in care to design and implement QI projects. Rick Bassett is an adult critical care clinical nurse specialist for St. Luke's Health System. He's board certified as an advanced practice nurse, certified as a critical care nurse, and a fellow of the National Association of Critical Nurse Specialists. He has served on local, regional, and national sepsis improvement teams and currently serves on St. Luke's Health System Inpatient System Collaborative. And last, but certainly not least, we have Dr. Halima Salisu-Kabara, who's a practice development consultant and the sepsis coordinator for Cito Sepsis Research Group, a multidisciplinary team in Nigeria, and the initiator of the Life Support Training Program. Her passion is knowledge sharing and networking, sepsis education, and quality improvement in healthcare systems. She also participated in the expert content development group, an external peer review group that developed the global report on the epidemiology and burden of sepsis, current evidence identifying gaps, and future directions conducted by the World Health Organization in 2020. I think it's safe to say we truly do have a stellar panel of QI experts with us here today. And so with that, I'm going to pass it on to each of our panelists one at a time to share their insights, beginning with you, Dr. Sean Townsend.
Fantastic. Thank you very much. It's a pleasure to be here today and have a chance to speak with everybody. I am taking care of patients this week, so forgive me that I don't have anything more formal than my scrubs, but I'm still glad to be here presenting. So the topic of leading change in sepsis care and trying to get people to recognize the disease process was our first challenge. Starting the sepsis campaign back in 2002, I came on board around 2004, and the first set of guidelines had been published. And our challenge at that time was to take these guidelines, which were, an evidence-based document, and trying to create change at the bedside. And that was a real challenge. I wasn't involved with the sepsis campaign at the point where they approached IHI, but I was at the Institute for Healthcare Improvement at that time. I just was finishing my fellowship, and the Surviving Sepsis campaign approached IHI and said, how do we change practice at the bedside? And IHI said, well, we have some ideas about that. Why don't you take this nice fellow and see if he can help you? And I got involved at really sort of the beginning of that work. And the approach that IHI had at the time was the development of bundles. Some of you may remember the first bundles IHI introduced were ventilator bundles and central line bundles. And just by extension, we thought, well, let's see if we can't do something similar for sepsis. And a bundle is a change management tool. It's simply making a discrete set of changes for people to know and understand that are easy to remember and evidence-based. And so we translated the guidelines into a set of bundles and began trying to promote them. And so that was one type of packaging we did to create change. And at that time, there was great enthusiasm and uptake for something new in the space of quality improvement. And sepsis really fit that bill. And so there was a lot of enthusiasm every time we would visit hospitals. The campaign really picked up very quickly and developed a national presence in no time. And then internationally as well, there was a lot of work that was done by the European Society of Critical Care Medicine. So I guess I'm speaking from a rather global perspective, right? Most work is done locally at the hospital, but it's hybrid, what I'm saying too, because we visited hospitals. We went to hospitals to make people hear what we had to say and have them hopefully absorb some of the changes. And they joined a campaign that was really grassroots. Nobody had any idea that this would take off as much as it did, but we began collecting a lot of data. And ultimately, we always knew that the next step to get to more widespread change would be to have a measurement strategy that we could promote, and that became a national measure. And it was years in the making. So I told you 2002, we began this nascent campaign, and it wasn't until 2015 in the United States there was a national sepsis measure. And that was based on that groundswell of people getting involved, hospitals being interested, the campaign collecting enough data to propose a measure, and then finally getting it passed. And since that time, the landscape has changed a lot. One of the lessons I would say that you learn pretty quickly when you develop something like that at a national scale is that you will always have detractors. And so what began with almost universal enthusiasms ultimately had a group of people who had opposition to the work and thought there were better ways or different ways to do it. Not opposition to caring for sepsis patients well. I would say even those that are opposed to the work we've done in the sepsis campaign and the measure we developed are well-intentioned and would like to care for sepsis patients with sepsis rather, in the best of ways. They just have different perspectives on what those are. And so I guess that's a second lesson, which is that you will pick up people who oppose you as you go along and try to do work to improve quality. Because again, I think it's important though that the third lesson that comes out of it is honor their intentions. Don't hate your enemies. Look at those people, and opposition is even a better word than enemy. Look at those people and say they have other ideas, and it's now a battle of wits about what the correct idea is in order to make change occur. Compromise is elusive. That's another problem that we have to face a lot of the time when working with people who oppose our ideas, but it's probably the best thing for the field if you can achieve it. And I have to admit, we've had some difficulty doing that with people who oppose our efforts. In sepsis care, the biggest controversies have been around antibiotic administration, and we encourage the use of early antibiotics. The opposition thinks that we maybe over-encourage that, and we could lead to resistance patterns, and that it's unnecessary in certain cases. We have overuse. That's a fair debate to have, and that's a real problem to discuss because we don't want resistant bacteria. So those are some quick lessons that I've learned along the way, and maybe as our discussion progresses, I could talk about local efforts of my own hospital, which I could speak to as well.
Fantastic. Thank you so much, Dr. Townsend. I'm now going to pass it on to Sybil Hoiss to share some of her own insights on leading QI initiatives, as well as some lessons learned. Sybil, you're muted.
Thank you. Thanks everyone for having me here today. I'm really grateful to be joining this excellent panel to talk about the work that's been done at Health Quality BC, formerly the BC Patient Safety and Quality Council. Now people actually know what we do, which is great. So the BC Sepsis Network was started in 2012. And it was led by is still led by a physician, Dr. David Sweet, who many of you know. And the start of the BC Sepsis Network happened because in 2010, BC was highlighted as having the worst sepsis rates in Canada. Of course, we're not interested in continuing with that, so we wanted to make some change. So we partnered with CIHI and UBC Sepsis on a collective project. And that included some site surveys, some process mapping, sepsis screen developments, and sepsis management plan. And in 2012, when the BC Sepsis Network was created, we worked with some sepsis leaders from Australia, Wales, and Scotland to share some learning and successes. And then we developed the provincial ED guidelines with a clinical expert group of physicians. And we also created some lanyard cards and sepsis PPO development. And to encourage use of those sepsis PPOs, we launched the 150 Lives campaign. And we used gamification to promote the use of the PPO. And so the sites competed against each other to see how many protocols and PPOs were used. And that was a way to create some excitement and get some engagement around the use of PPOs. And then in 2015, we developed the Inpatient Sepsis Toolkit. And that wasn't just us developing it. We worked with leaders across BC to create that. We developed some QI resources to increase awareness and help with monitoring and improvement of sepsis treatment in the inpatient units. In 2017, we had a call to action with ED sepsis algorithm and a lanyard card for direct care staff. We also developed an inpatient lanyard card to help support the treatment of sepsis on inpatient units. And in 2019, we developed a patient brochure and infographic because that was a gap that we noticed. And then in 2021, we did an ROI study with the UBC health economist. And what that led us to understand is for that every $112.50 was saved for every dollar invested in the BC Sepsis Network. So all the work that that we were doing helped save $112.50 for every dollar invested. And then the in-hospital sepsis incident rate dropped from 4.5 per thousand in 2012 to 3.5 per thousand in 2017. So fairly significant drop, I guess. In 2022, so recently, we updated the ED and inpatient guidelines and education resources. We also added posters with key messages for emergency departments and inpatient units. And these posters can be put on every computer screen in the hospital, whether it's the bedside computers or you know, those monitors sometimes that are available around the hospitals. They were also designed to fit perfectly on PowerPoint slides to help promote some education. And one of the key things we did is partner with the BC Emergency Medicine Network of Physicians and Administrators. We co-branded and partnered recorded webinar and practice resources so that people practicing in the units knew that there was an agreement between the BC Sepsis Network, or alignment, I should say, between the BC Sepsis Network and the Emergency Medicine Network, so they knew that they could trust the resources that we created. So we recorded and disseminated a webinar. We disseminated practice resources. And now the BC Emergency Medicine Network is a formal structure called Emergency Care BC, and the BC Sepsis Network is still partnered with them, as we move forward now on emergency department dashboards. And so since 2017, we've been collecting data for process measures at the major emergency departments in BC. So those emergency departments that are on the same site as an ICU within BC. And so these dashboards have started. We're currently working on distribution, communication, and an action plan. Because now we do have formal structure within BC with Emergency Care BC and Critical Care BC that I'm now working with. So these are new health improvement networks at PHSA that give provincial oversight and support. And so currently these dashboards, we capture process measures. So the time of the first lactate, the first liter of fluid, the second liter of fluid, the second liter or second lactate within 2 to 4 hours of the first, if the first one was greater than 2, blood cultures before antibiotics, and antibiotics within 1 hour if the patient is in shock, and within 3 hours if not in shock. And we also track ICU length of stay and mortality. And the reason that we track these things is because our hope is that when we send these and talk with the emergency departments about their progress, the things that they're doing really well on, they might not have to spend so much time on, and they can instead focus on the areas where there's the most unwarranted variation, and they can make the most improvement. So it's really concentrating their quality improvement efforts where that's needed most. And also we've partnered with Child Health BC. That's another health improvement network within British Columbia. And they have worked with their expert group to create urgent and emergent sepsis guidelines. So they've just updated their guidelines with Child Health BC, and they're now posted on the Child Health BC website and as well as ours. So that if people come to us looking for sepsis guidelines for the pediatric population, they'll find the link to the Child Health BC website. So it's kind of like a one-stop shop for all of the guidelines related to sepsis in BC. And so that toolkit was created to provide recommendations and best practice for recognition and treatment of pediatric sepsis, suspected sepsis or septic shock. We wanted to support a standardized practice of pediatric sepsis care across BC. And we also wanted to provide patient and caregiver materials when a child is suspected of having or is diagnosed with sepsis. And Health Quality BC partnered with Child Health BC on these patient resources, in that our patient and public engagement team worked with them to help support patient and family engagement and the creation of resources to support that knowledge translation. And so our website houses all of that. And the toolkit contains a pediatric sepsis recognition and management guidelines for emergent and urgent care, pediatric sepsis screening tool, a care algorithm, patient and caregiver resources, and resources to support education. And we also, the BC Sepsis Network also partners with UBC Action on Sepsis. We partnered to create a post-sepsis syndrome discharge pamphlet for adults with a research cluster participation. We also partner with Sepsis Canada for this conference, for World Sepsis Day coordination, and to increase awareness. As I mentioned, Child Health BC. As the BC Sepsis Network, I reached out to the BC and Yukon Skin and Wound Working Group to help distribute and raise awareness about the patient teaching and discharge pamphlet distribution. I also connected with our professional practice leaders across BC to raise awareness of provincial resources to support the health authorities. I reached out to nursing schools to help incorporate these resources into nursing and allied health curriculum to promote the use of the algorithm and guidelines and raise awareness of the prevalence. And also the BC Simulation Network, because we created a scenario with them that includes the BC Sepsis Network ED guidelines and algorithm. And this is now also available for med schools, RT schools, and nursing schools through SIM support. And just, I'll finish off here with some future plans. So we want to try and socialize those ED dashboards and integrate them into quality improvement activities. We're also doing a BC sepsis scan. So we're trying to gather a picture of how sepsis is being managed across acute, community, and long-term settings. And we continue to promote awareness for sepsis, resources to support treatment and recovery, and resources to support healthcare professional and staff knowledge translation.
Awesome. Thank you so much, Sybil. And I think it's people are already putting in the chat lots of questions around these resources. And I think, even just you and Dr. Sean Townsend sharing your initial thoughts and perspectives already seen so many important similarities between, driving local initiatives, the importance of external stakeholders, and how to implement sustained QI initiatives. So thank you both for sharing. I'm going to pass it on to Rick Bassett next.
Great, thank you so much. And I am glad to be here with you. So I, like Sean, have been involved in sepsis since the early 2000s as far as the creation of the original sepsis bundle. And some of you might remember Zygris and other things like that have come and gone. There's been a lot of changes over the last 2 decades. And I think we've learned a lot. One of the things I wanted to just reflect back on, one of the phrases that Elizabeth talked about, which is translation into practice. That's been a big part of my role here at St. Luke's, as well as on the national scope with a critical care, national critical care collaborative that I was part of. And I think it's important that we make sure folks are aware of and understand the evidence, because if they don't know the why, then they're less likely to engage. So let me fast forward now and talk a little bit about what we've done more recently here at St. Luke's. One of the more important things is to help focus your team, and sepsis is a big piece of what we do for many different diagnoses, but having identified 4 pillars for sepsis assessment and reassessment has been a big part of our focus now. The first part of that is antibiotics, and it's not just the choice, but it's also the timeliness of administration. Sean talked a little bit about the controversy with regard to antibiotics. We've had a lot of discussions about that. We keep track of our antibiogram, and we make changes as needed, but we want to make sure that the providers on the front line, they have the best resources possible to make those decisions in the heat of the moment. Secondly is fluids, and I know that there's been a lot of discussion about that, not only at prior sepsis conferences, but also at hospitals across the world with regard to what is appropriate. And I will tell you that at least in the United States, there's been a lot of focus on SEP1 about how do we meet the CMS measures, things like that. But over the last few years, more and more hospitals have been more focused on what's the fluid therapy appropriate for this patient. And so that's what we are focused on as well, and making sure that the providers have what they need to document why 30 mils per kilo was appropriate, why it wasn't appropriate, and making sure that we're also taking a look at the patient's fluid responsiveness. That's something that is something we didn't have 20 years ago, but something that we do have today. Source control is one of the other things we often don't know, especially when the patient comes in the ED, what the source of the sepsis is, and making sure that we have some kind of a source control for that beyond the antibiotics, beyond the fluid. And then lastly, vasopressor use is something that we don't want to take lightly. We want to make sure that we're using vasopressors appropriately, and that we're using vasopressors in an appropriate order as well. So as part of any critical care, any sepsis collaborative or program, is to keep in mind the following: identification timeliness of identification, and that looks a little bit different on the inpatient than it does the ED. Resuscitation, in my opinion, really the fundamentals of resuscitation, whether it be in the ED or inpatient, are basically the same. We want to be doing those things in a very timely manner. We don't want to be wasting time. And then third is that stabilization period. As that patient starts to stabilize, we start looking at de-escalation of the antibiotics. We start looking at de-escalation of the vasopressors. Hopefully by then we've already looked at the fluid status and that's stabilized as well. The workflow for each of these, though, may look a little bit different in the ED versus the ICU versus the floor. And I can tell you from my experience, not only just at St. Luke's, but on the national level, this is something that teams can struggle with if they don't try to kind of acknowledge the fact that they are different. And so when we build a comprehensive sepsis program, we want to be able to shift gears from the ED to the ICU and then out to the floor if the patient takes that pathway. So I'll tell you, just at St. Luke's, we started with sepsis, our sepsis program in our ED very many years ago, and really probably about 20 years ago. And that was our initial focus, but we expanded our focus to inpatient sepsis shortly after that, probably 2005, 2006, when we initiated our rapid response team and related protocols. Since then, our protocols have become more robust, and they're not only doing all the labs and everything like that, initiating consults with pharmacy, but also giving fluids, things like that, contacting the provider, making sure we have all those things in place, and that we're really initiating a timely response on the inpatient side, just like we have in the ED. And as we talk about sepsis programs and sepsis QI, it's also important to discuss the differences between ED sepsis and what that looks like in inpatient sepsis, because I will just say ED sepsis often presents as that diagnosis, the patient's septic, but not always. However, in the inpatient side, sepsis can often be seen as a secondary diagnosis. It kind of creeps in there. We're focusing on this patient who's had an orthopedic surgery, or they had some other kind of a treatment that we're focusing on, and all of a sudden we start seeing sepsis signs kind of creep in. So it's important that our staff understand the initiation of the rapid response process, which we have a very robust set of criteria that our staff are aware of. And so when they activate that rapid response team, which are all seasoned critical care staff, they can come, they do an assessment of that patient using an objective sepsis identification tool. And then once they have that tool and they've identified that sepsis, that really becomes our time zero, which is a little bit different than ED. Sometimes EDs define the time zero as door to treatment, and others define it as identification to treatment. When I talk about the time zero, though, it's also important to note that, and at St. Luke's we use Epic. I know that there are many organizations that use Epic across the nation and probably world as well. And we have a sepsis timer. And the second the physician puts in the orders, part of that, those orders are the sepsis timer. And so it doesn't matter whether we start the fluid therapy, antibiotic therapy, whatever, in the ED or in the ICU, wherever it is, that sepsis timer starts. And as that patient transitions from one location to another, that timer continues, and the staff can be able to see, I need to get this started at this certain point, or this never got started, I need to address that. Lastly, I just want to mention that, I think Sean kind of alluded to this. We've had substantial improvement over the years in our workflows and our processes, and the evidence that we found are grounded in with regard to our sepsis programs. We also monitor our mortality rates. And I want to reflect back on what our opening session was, which was about, one of the things that were mentioned was about the long-term ramifications of acute illness. And so it's not just about making sure these patients survive their sepsis. It's about making sure they have a functional survival of their sepsis event. And lastly, the other thing that I want to mention is when you look back at the public awareness of what a heart attack is and all of the information that's been sent out through marketing and the airwaves and stuff like that, not just within hospitals, but actually public awareness campaigns. Same thing with stroke. How many people, lay people, know what a stroke is and what the signs are? We haven't really done a robust job of making people aware of what sepsis is. And I mention that because sometimes by the time people come into the hospital with sepsis, they are so sick. And that often limits our ability to restore them to a full function just because they've waited so long. So I'll stop there and appreciate this opportunity.
Thank you so much, Rick. And I just really love your last point around making sure that, when patients are coming into the hospital experiencing sepsis and leaving, want to make sure that their functional outcomes or quality of life are considered. And I think that was really, really highlighted in our first panel discussion this morning with our patient and family partners. So thanks for bringing that to the forefront. And so with that, I'm going to pass it over to Dr. Halima Salisu-Kabara to share with us some of her insights on QI initiatives.
Good evening, and I would just like to pay my respects to the elders and the past and present descendants and custodians of this land, that you live in. So we honor the knowledge, keepers, and we continue, to adore them for all they have done. From my own perspective now, I will talk about Africa and the work we've done in Africa. And as a nurse-led and coordinated sepsis care for Africa. So we started, I think I started in 2012. After a visit to Dubai, the Emirates Critical Care Conference, where I met, so many critical care experts who were so much interested in, low and middle income countries and how, to improve the sepsis care, in that area. And so they set up a session. And that session, was, dealing only on sepsis in low and middle income countries. And there we have the opportunity to discuss our problems, the challenges we face and, the work we do. So that's where we started. And as soon as I got back to my country in Nigeria, I felt there's a need, to change some of the things that are on ground because in fact, when I took a small sample poll, I realized that most people had not heard the word sepsis before, and I was in a dilemma of how to even explain it in my dialect, in my language. It was so difficult because anything you say is like the opposite of what sepsis is. Like saying maybe blood poisoning, whatever, because in the language you have that, but you don't have what sepsis is. So, and up to date, we could not define sepsis on itself. So that's one of the main areas of barriers that we have. So talking about innovation and quality improvement, I realized that the most important part of what I should do should be advocacy and creating awareness and sensitizing, the public first, because they come from the communities, where, they have, they are overburdened with many diseases and, issues like, having lack of access to hospitals, having poverty. They do not have the power to seek care. So starting from there, then to the healthcare workers. Now to get to the healthcare workers throughout the country and as well as Africa, I had to go through the critical care organizations, the societies, in Africa, with critical care units, because some of the countries do not even have intensive care units. So they do not even have critical care practitioners. So you can imagine what happens there with the sepsis patients. So now we have created the African Sepsis Alliance, which was an initiation of ours, and from there we are able to reach out to the African countries, and I also pioneered the creating of the African Federation of Critical Care Nurses, and so we have many African countries now represented, and we are able to have conferences. Sometimes we have biannual, and sometimes we have yearly in different countries, and we have sepsis as one of the sessions that we take in those conferences, because we realize that we have a very high burden of sepsis in Africa, and for the fact that we also have issues with infrastructures. So we really have a lot to do. Now, looking at the leadership, because you need political will. Getting this is, has been a problem, from the inception, for you to get the hospital executives or the management, to support, your initiative of putting together some sepsis group, that was a big issue. But at last, we have the sepsis incidence and determinants outcome in Kano as a group, a sepsis research group, and that's a multidisciplinary, team with everybody involved, from the environmentalist to the surgeon to the microbiologists and all of them. So, and that group is in place, and we are carrying out researches. First, we have to get the data together and show them that this is why we need to have changes, put in place. So we are into researches, and we have 2 researches that are on board, and hopefully, when we get the findings, we'll be able to, implement some of the World Health Assembly's resolution on sepsis. Now, the resolution is there, and most countries, well, my country has not been able to do much on that because we do not have any home, where we can develop our national sepsis action plan. And we have also the other issue of microbial resistance, which is really, really a big problem, and that is what is driving sepsis incidence in my country.
Halima, it's a little challenging to hear you. Can you move closer to the computer, please? Oh, I think we've lost your audio. No, still can't hear you.
Looks like she's muted.
Halima, we can't hear you.
Okay, no worries. Halima, I'll give you a few minutes to get your audio sorted. No problem, it totally happens. So as Dr. Salisu-Kabara is sort of getting that sorted, I think she's pointed out a really important point for us to consider. You know, we've been talking about the fact that sepsis can affect anyone. We've been talking about, you know, adult and pediatric and neonatal populations. Dr. Elizabeth Bridges brought up a really important point around social determinants of health. And now Halima has highlighted the importance of understanding the context, the resources, the personnel, and all the multiple facets that need to be considered, both in QI initiatives related to sepsis, but also in research and care. And so I want to go to you as the experts who, you know, run multiple QI initiatives, both locally and, you know, nationally and internationally, have now been recognized. And I wanted to ask the question around, you know, when you're starting system changes, do you start with knowledge? Do you start with engagement? You know, reflecting back on initiatives you did early on versus more recent initiatives, what have you learned about initiating that process of implementing new QI changes? And this is open to any of our panelists, so please feel free to jump in.
Well, this is Rick, and I do have an approach that I use for all initiatives. It doesn't matter what the initiative is. I kind of hinted on it when I was giving my little opener there, but bottom line is people need to know what we're doing. They need to know why we're doing it. They need to know what their role is in the process. And they also need to know what the role is for everybody else, because if I don't know what the physician's role is, I don't need to know the details, but I just need to know they're responsible for this piece, I am for this piece, etc. When we don't have that level of knowledge amongst our team with the why, the what, and the how, and the who, then people either they can be engaged, but they're confused, they get frustrated, and then you have a problem with sustainability of the initiative.
Thanks, Rick. Dr. Townsend, Sybil, anything to add to that?
Yeah, I will for sure. I agree with Rick. One of the reasons I think some of our quality improvement initiatives have been really successful with our health authority partners is that we reached out to not only the leaders, like the senior leaders and middle level executives, but also the direct care staff and the educators leading them to find out what was working for them, what wasn't, what gaps were there, and then work to provide some resources or education materials to meet those gaps. We might think as leaders that we understand what's needed to get that work done, but the second that we step away from bedside, we are no longer the experts. And so we need to go back and ask those folks what they need from us to help do the work that they know needs to happen. There's, you know, a lot of information about including people in the engagement activities. And I'd also say reporting back to them the results of the work that they've done. That's one of the benefits of the ED dashboards that we currently are trying to socialize, is that we can show all of the direct care staff how they've improved since 2017. And then as we start providing them with reports on these dashboards over, you know, 6 months time, so every 6 months kind of showing them what their results are, we're able to congratulate them for the work that they've done and show them that their efforts to improve sepsis care and help support patients and families in that is actually working. And that increases engagement more, and people want to, you know, they want to participate more. And we need to continuously reach out to them and find out what's working for them and what's not. And I think that's a key for making quality improvement initiatives successful, is to include the people that are actually doing the work.
Awesome. Thank you so much, Sybil. Anything to add, Dr. Townsend?
I'm going to second both of the remarks. One of the approaches I've used to facilitate that is letting the frontline team members define the goal and the time period over which they want to achieve it. So if you approach people and say, okay, you want to work on sepsis, you want to achieve better compliance with fluid administration, okay, where do you want to be in 6 months? And let's make that as our goal, and let them decide where they are now, from where they are now, if they can actually achieve that. And that just gets invested, and they become invested then in a target that they've set themselves. And otherwise, if I define the targets, it's, well, that's what he said, right? I want them to be the ones to make the decision. And so I find that strategy oftentimes helpful. And you'll oftentimes get a bunch of empty stares, but you have to just wait long enough for people to start making suggestions about what they think they could do. So I tend to like that approach.
Fantastic, thank you. Halima, I just want to see if your audio is now working and if you want to wrap up your thoughts there. If not, please feel free to put it in the chat and I can read it out as well. Okay, maybe not. I was just, oh, go ahead. Okay, sorry, we can't hear you. I do apologize, but if you wanted to type it in the chat, then I'm happy to read it on your behalf. I think a lot of the comments that are happening in the chat are just emphasizing that importance of involving all the different stakeholders, including them in the decision-making process, but also reporting back in order for that sustained involvement. I know we do need to wrap up very quickly and very shortly. So I just wanted to turn it over to the panelists to ask about any final thoughts. I think each of you have been instrumental in your respective institutions in areas of practice and implementing QI initiatives. What are some, top of mind thoughts for other institutions considering similar QI initiatives that each of you have led? And I'll go to you first, Rick.
Yeah, I'll just briefly say that, and I think many people know this, sepsis work is not a set it and forget it kind of a thing. You can put a program in place and that program is working great. The evidence changes, the culture changes of your staff, you get new staff in. It is constantly something that you need to be massaging, you need to be working on and making sure that you're staying eyes on target. And also, sometimes you will shift your metrics. You will go, you know what? This isn't a challenge for us anymore. We've been 100% for the last 6 months. Let's shift our focus onto something else.
Thanks, Rick. I'm going to pass it on to you, Dr. Townsend.
Rick's comments on staffing are absolutely right on. Especially after the pandemic, we saw such shifts in changes in our nursing staff and our physical therapists and occupational therapists and pharmacists and so on. It was remarkable. I would say we're starting to stabilize, but I'm not sure that we actually resemble the same staff we had prior to the pandemic. A lot of our leadership changed as well. Managers, directors left, took different roles and different positions. So while it feels like Groundhog Day to start again and re-educate, it really becomes necessary for the new staff because they don't know your order set. They don't know how it integrates with some other order set. They simply have to be taught and to learn it again. And so re-education is an important aspect of it. I think, and the one way to engage those employees, the new employees as well, is when you're going to make a change in your process, bring them into, if you use Kaizen, if you're doing lean work, that type of thing, or whatever type of even committee work to make change occur, but bring them in as part of the committee to get them involved. Similar to my remarks about goal setting, the more you do with the front line involved, the more successful your work will be. The more top down you hand stuff to people or send things out by email, your chances are lower. So engaging the front line, I think, is critical at all phases of this work.
Awesome. Thank you, Dr. Townsend. And I just wanted to read out a few remarks from Halima here saying, I'm trying to link our work to the development of multidisciplinary teams, building the capacity by training and educating the healthcare workers on sepsis and how to build a more resilient team. So coordinated, proactive teamwork. And just really quickly, Sybil, pass it to you for final remarks and thoughts on this.
Thank you, Fatima. I would really highlight one way to keep engagement, to get and keep engagement with the staff, definitely to include them, but also to build relationships with these people. We don't just want to send an email out to them and expect that things are implemented. I think in order to make meaningful change, we have to really foster those relationships. We need to celebrate successes with them. And we need to help provide them with resources when they are unable to meet those needs or their goals. Like, for example, Sean, you were mentioning that it's really important to have people identify their own timelines, and absolutely, I totally agree with that. And on top of that, if they're not meeting those needs, well, what's the gap? How can we help bridge that gap so that the people doing direct care know that they're supported and they're in alignment with our goals, and like their goals and our goals are aligned, so that they feel supported in the change and supported even if they're not able to meet those pre-identified goals. We can still help support them. And so if they know that they're supported and we keep reporting back to them about their progress, we'll keep and maintain those relationships.
Awesome. Thank you so much, Sybil. And I see David is back online, which is my cue to wrap this session up. So with that, I just want to say a massive thank you to each of you for being part of this session. I know I've learned so much, and it looks like the chat is going off and there's still lots of questions. So thank you all for being involved and for sharing this time with us. Thank you.
Yeah, thanks, team. Wow. And Fatima, thank you for your leadership in guiding us through this. I had multiple people texting me about what an amazing moderator you are. Our next session, let's see if I can multitask, which we know humans can't, but I'll try. Our next session is kind of one I pushed for because I'm confused. The more I learn about fluids and sepsis, the more confused I am. And I've been in intensives for almost 20 years. I'm going to introduce our moderator for this session, Dr. Mary Jo Kelly, one of the people that's taught me the most about implementing change around sepsis. Dr. Mary Jo Kelly is an advanced practice registered nurse, has a doctor of nursing practice, and is a clinical nurse specialist at Swedish Medical Center in Seattle, Washington. She has more than, am I allowed to say, 20 years of experience improving patient care delivery through personalized support and ongoing attention. She really goes to the bedside to engage those teams. She's also a nurse specialist with FEMA, the Federal Emergency Management Team, and has overseen operations both in disaster settings, but also in public health settings, really vaccinating maybe the majority of the city of Seattle. I'm not quite sure. In recognition of her leadership in the healthcare industry, she was awarded the 2021 Daisy Nurse Leader Award, a very prestigious award. And today she's moderating our session. Mary Jo, I will leave the slide up with our speakers until you're done introducing them, and then I will stop sharing.
Thank you, David. I'm very excited to moderate this session because I want to hear their answers as well. We take this information and go to the bedside with it quite a bit. So we have panelists that are going to address the question of what fluid, how much fluid, and what about the pediatric population? Do we adjust our fluid requirements for them? Our panelists come from Australia, Seattle, Washington, and Ontario, Canada. I'm going to introduce all three of them and then give them the space to educate us. So our first speaker is Dr. Anthony Delaney. He's joining us from Australia. He is a father of three. He's a fellow of the Australian College for Emergency Medicine and the College of Intensive Care Medicine. He's currently a professional fellow in the Division of Critical Care at the George Institute of Global Health. Dr. Delaney also holds appointments as associate professor at Sydney Medical School in the University of Sydney and is an adjunct senior research fellow at the Australian and New Zealand Intensive Care Center. Dr. Delaney maintains a clinical role as senior staff specialist in the Malcolm Fisher Department of Intensive Care Medicine at the Royal North Shore Hospital. His major research interests are centered on improving methods of resuscitation of patients with sepsis, septic shock, and improving outcomes for patients suffering from acute brain injury. Today, Dr. Delaney will be discussing fluid resuscitation and sepsis and choosing the right fluid. And then one of my go-to people, Dr. Nick Johnson from Seattle, Washington. He's the associate professor and a section head of critical care in the Department of Emergency Medicine. And he is also an associate professor of medicine in the Division of Pulmonary and Critical Care and Sleep Medicine at the University of Washington at Harborview Medical Center. Dr. Johnson's academic interests focus on ventilation, oxygenation, and critical care after out-of-hospital cardiac arrest, as well as clinical trials focused on early critical illness, including sepsis. Today, Nick will be discussing lessons from the Clover's trial, choosing the right volume of fluid resuscitation. And then we have Dr. Melissa Parker, Associate Professor of Pediatrics and Health Research Methods, Evidence and Impact at McMaster University in Ontario. She is board certified in pediatric critical care medicine and pediatric emergency medicine and holds a master's in health research methodology. Dr. Parker is the principal investigator of the recently completed SQUEEZE trial, investigating fluid-sparing resuscitation strategies versus usual care in the pediatric patient with septic shock. Today, she will be providing the pediatric perspective on fluid resuscitation and septic shock. So I'm going to turn this over to Dr. Delaney to start our presentation.
G'day. G'day. Thank you very much for the opportunity to speak. So as I was kindly introduced, my name's Anthony Delaney. I'm going to try and share my screen, if that's all right. And then hopefully you guys can see that now. I'm just going to talk a little bit about choosing the right fluid for resuscitating patients with sepsis, and just start by acknowledging that I don't have any conflicts of interest, that I'm currently sitting on the land of the Darug and Gurungai people in the northern part of Sydney. And I'd like to offer my thanks and acknowledgement to all the trial participants and families of those who've been in the clinical trials that have really helped us improve our knowledge about what fluid to give. And I also should acknowledge the work of one of my colleagues and friends, Dr. Naomi Hammond, who's done a lot of work in this space as well in terms of determining which is the right fluid to give to people. And I'm certainly not a world expert in this, but I'm just offering you my 2 cents. And what I thought I would talk a little bit about was just really 3 things. One, the first one is probably the easiest thing to talk about, which is what's the wrong fluid to give. The next thing will be a bit about the evidence that we've been looking at, which helps us determine which is the right sort of crystalloid fluid to give, and then think a little bit about what we might do next. I'm certainly not going to, I'm glad I'm not the next speaker along. I don't want to be wading into the argument about how much fluid we should be giving, because that's a sort of complicated topic. So I'm going to start with the easiest part, which is what's the wrong fluid to give. And I think we've now got pretty good evidence from largely from a large Scandinavian trial, but from also some other work that tells us that hydroxyethyl starch and the sort of artificial starches are the wrong sorts of fluids to give to patients when they're being resuscitated from sepsis. And most of this evidence comes from a large clinical trial that was done in 804 participants with severe sepsis. There was really a well-done, high-quality trial conducted in Scandinavia. And what they demonstrated was that compared to the use of a balanced crystalloid solution, that the use of hydroxyethyl, one particular hydroxyethyl starch, I suppose we should be clear about, was associated with actually an increase in mortality as well as an increase in renal replacement therapy. And that's made it pretty clear that we should be avoiding the use of artificial starches for patients with sepsis. And that has been reflected in the most recent Surviving Sepsis Campaign guidelines, where they give a really strong recommendation to avoid starch based upon quite high quality evidence. And knowing what not to give doesn't really help us a whole lot. We sort of would like to know what to give. And And I think for most people in most settings, the place to start for resuscitating patients with severe sepsis or septic shock comes using some crystalloid. The question then is, which crystalloid should you use? I don't think there's a lot of doubt that the evidence would support using a crystalloid. But which one are you going to choose? And for years, probably the most commonly chosen fluid was the sort of poorly named normal saline or 0.9% isotonic saline. Whereas more recently, there was some thought that maybe the hyperchloremia that's associated with the delivery of large volumes of saline might have adverse effects. And so there's a question that perhaps we should be using more balanced crystalloids. And that's something that we looked at, the overall evidence for crystalloids versus saline in critically ill patients, with a particular focus on patients that have sepsis. So what we did, and where I think we can add something to this discussion, given that the evidence in the most recent surviving sepsis guidelines actually didn't include the two biggest trials and didn't include this overview. So we did a systematic review and meta-analysis where we looked at all critically ill adult patients. So that's those who were cared for in an intensive care or high dependency unit, where they received an intervention that was a balanced salt or a low chloride solution, so plasmolide or Hartmann's or lactated Ringer's solution, compared to 0.9% saline, and where they measured some sort of mortality, preferably at 90 days, as well as some other pre-specified outcomes. And we included both the individual patient randomized trials as well as the cluster randomized trials. I'll quickly run through the methods. They're not so interesting, but we did a really thorough search using a bunch of mesh headings and keywords. We had two people going through all the aspects of the trial, the screening and the eligibility assessment, the data extraction and the risk of bias assessment that was done by people who were not involved with any of the included trials. We stuck our protocol for our review up so it was publicly available before we did it and conducted strictly according to that protocol. And what we were interested in measuring was 90-day mortality or whatever was closest in the trials that were assessed only as low risk of bias. We also looked at a number of other outcomes such as acute kidney injury, the vasopressor free days, how quickly you got off ventilation and stayed off ventilation if you're alive, mortality at the longest reported output. And we tried to find quality of life and functional outcomes, knowing that, you know, one of the things that the survivors tell us after they get through sepsis is that they're interested in how they're getting along long-term rather than just getting through the acute event. Importantly for this sort of forum, we specifically went looking for trials or patient-level subgroups of patients with sepsis because we thought that might be an interesting group because they often receive quite large volumes of fluid. We did some fancy statistical tests on the numbers. Primarily just did a normal frequentist analysis with a random effects model, but we also, of interest, did a Bayesian model afterwards to see if that would help us make some sense of the numbers. And what we found was, after going through about 1,700 studies, there are actually 13 whole trials looking at this question of whether you should use balanced fluid solutions or saline. The risk of bias, so there were actually 6 trials that were adjudicated as having low risk of bias in all domains, as well as a bunch of other trials with sort of moderate, only a couple of domains missing for high risk of bias. And when you put it all together for the overall estimates of whether balanced fluids are better than saline, the estimated relative risk was a 4% relative risk reduction, with 95% confidence intervals that stretched from sort of a 9% risk reduction to a 10% relative risk increase. And that wasn't statistically significant from 0. But the Bayesian analysis gave us a posterior probability of 0.96, so very similar, as you might expect using the vague priors, but actually an 89% probability that balanced a solution was better than saline to some extent, with regards to mortality. So the full distribution of the full posterior distribution looks something like this, where it's about 90% of the risk ratios were less than 1. So while you couldn't be certain with the same level of confidence that you would using the standard analysis, it seemed pretty reasonably clear maybe that there's a suggestion that balanced salt solutions might be better than saline. Of particular note, when we went through the individual trials, a bunch of the trials had subgroups with sepsis, and we were able to pool those subgroups. And what you find when those subgroups are pooled is that the results are very similar, with an estimated risk ratio of 0.93 and confidence intervals that only just cross 1. And we didn't perform the secondary Bayesian analysis on all of the different subgroups because it gets a little bit tricky doing that. But you'll see that the p-value for this is 0.07. So just on the side of missing the traditional level where you'd call it statistically significant. So again, it's not something that I think we can be definitive about, but there's certainly a pretty strong suggestion that balanced salt solutions may be better for resuscitating patients with sepsis compared to saline. We would expect to see some more information on this soon, in that the clinical trialists who've been involved in all of the major clinical trials looking at this issue have collaborated and are currently putting together an individual patient data meta-analysis. And I would hope that from that individual patient data meta-analysis, we would be able to get some more granular data and hopefully some more certainty to confirm or refute the possibility that you can be sure that balanced salt solutions may be better than saline for these group of patients. So one of the questions that often comes up particularly for the sicker patients is that they've had their 30 mils per kilo or 2 or 3, sometimes even more litres of fluid where they're getting a whole lot of crystalloid. And there has been, as I'm sure we're going to hear about soon, there has been questions raised about the use of really large volumes of fluid for patients with sepsis. And some concern that giving large volumes of fluid might be hazardous. And so there's one of the ways that one might get around that would be to use a colloid fluid rather than a crystalloid fluid. And knowing that the starches are probably out and there's very little evidence for the other artificial solutions, the thought was that perhaps albumin might be the next thing you would choose for patients that are getting large volumes. Again, the recommendations for that in the Surviving Sepsis Campaign guideline are not so strong. And this is a question that we'd taken up some years ago, as a matter of fact. And I think it might be the next place that research goes with regards to defining the best fluid for patients with sepsis. So why might you choose albumin? It's got a lot of biological functions, transporting biologically active molecules like hormones through the body. It helps maintain plasma or osmotic pressure. It's hard to talk at this time of day down here. For patients that are sepsis, microvascular aggregation, microvascular DIC type problems where there's a whole lot of platelet aggregation can be a problem. And albumin is known to inhibit platelet aggregation. And it can also act as an oxygen-free radical scavenger. So there's a biologically plausible reason why albumin might be beneficial, both as a fluid, but also as a therapeutic intervention for patients with severe sepsis. We looked at this some years ago, and you have to take some of these results with a little grain of salt. There are a couple of newer trials that are not included in our previous meta-analysis, and some of the trials that you'll see in the middle there not only no longer appear in the medical literature, they probably never were real. And I think the ex-Professor Bolt is now in prison for fraud. Having said that, we did conduct at the time, we conducted a sensitivity analysis prior to those being retracted from the literature, and the results were the same. And when you compare the use of albumin to any comparator fluid for patients with sepsis, you do get a statistically significant reduction in mortality with a decent estimated relative risk of about 0.82, which sits just at the point where you'd say that that was statistically significant. And that was particularly noted in trials where it was compared to crystalloid. You can ignore the starch line, they're all the made-up trials of Professor Bolt. But compared to crystalloid, there did seem to be a statistically significant reduction in the chance of dying when albumin was used. So I don't think we've got a definitive answer as to whether we would use albumin yet, but I think it might be the next place that the research will head, and I certainly hope it will, because I think that there is a role for having an alternative approach when you've had quite a bit of crystalloid fluid on board. So which fluid would I use for patients with sepsis? I definitely wouldn't be using starches. I think we've got enough evidence to say that we should be avoiding those. I think we'd probably start for almost everybody with a crystalloid, and probably a balanced crystalloid. It may depend a little on what place of the world you're in and whether there's an increased cost associated with some of the balanced fluids, salt solutions. But for most places, I don't think that there's a huge cost difference, and having a 90% chance that it's probably better is probably sufficient, I think. It certainly would push me to using balanced salt solutions rather than saline for patients with sepsis. And after we've given patients 2 or 3 litres of fluid, we would be thinking about using human albumin. Again, in Australia and New Zealand, there's no cost implication. It comes from our National Blood Authority, and hospitals aren't charged for it because it's donated freely. So we don't have an issue, again, with the cost of albumin for using for our patients. So that's where I would be going for in terms of choosing the fluid for patients with sepsis. And if anybody had a question or even a long rambling editorial comment that they'd like to make disguised as a question, I'd be more than happy to field them, or just sit around while you made your comments.
Thank you, Dr. Delaney. We'll take questions after all 3 presentations. Nick Johnson, will you present next?
Absolutely. Thank you, Mary Jo, and thank you all for being here. And thanks to the conference organizers. This is always one of my favorite events, and I love the evolution of this conference over the years I've been able to join. Just going to get my screen up here. All right. So I'm here to talk with you all today about a challenging topic. As Professor Delaney just highlighted, fluid resuscitation and sepsis, focusing on fluid volume, and specifically hope to chat with you a bit about lessons from the recently published CLOVERS trial. My disclosures are here. I think the only one relevant to this talk is that I was one of the study investigators for the CLOVERS trial and for the NHLBI PEDAL network, among many hundreds of others who participated in this work. And most of my other work is related to sepsis and cardiac arrest resuscitation. As I've mentioned before, when I've spoken with members of this group, I do have an intellectual disclosure, which is I really believe strongly that fluid is a drug, and like any other drug, we should be giving the right agent to the right patient at the right dose and the right time. And I think the CLOVERS trial helps us get a little bit closer to helping us understand some aspects of this, but not all of them. So our goals today are threefold. I'm hoping we can talk a little bit about the impetus for the CLOVERS trial, but I think you're all pretty familiar with that. We'll talk about the design and some of the key results of the trial, and then we'll spend the most time talking about some key implications and hopefully a path forward for fluid resuscitation and sepsis. So the background on which the CLOVERS trial was designed was this. There were guidelines, and still are guidelines at the time, emphasizing generally more aggressive resuscitation for sepsis. There were some observational data indicating potential harm with this approach. And then there were 2 randomized trials published prior to initiation of the CLOVERS trial in very different patient populations, the FEAST trial and the CLASSIC trial, indicating potentially increased adverse outcomes with an aggressive fluid resuscitation approach. There was also a mounting body of literature across a lot of disease states, including sepsis, demonstrating association between positive fluid balance and harm at various stages throughout critical illness. This was a systematic review and meta-analysis of many of these studies. Over 20,000 patients included, with a cumulative fluid balance of 4.4 liters, and a positive fluid balance at the 1 week mark was associated with a number of complications, including increased mortality. Of course, the question in all of the fluid balance literature is causation versus correlation in patients who receive and need more fluid resuscitation and lose less volume via the normal routes probably are sicker than those who don't. So this literature is likely highly confounded by indication. And there were also a number of relatively small randomized controlled trials published prior to the CLOVERS trial, all with relatively null results, kind of down the middle, leading to equipoise regarding whether a global strategy of restrictive or liberal fluid resuscitation is the right one in sepsis. So enter the CLOVERS trial. So this trial was conducted within the U.S. National Heart, Lung, and Blood Institute PEDAL Network, Prevention and Early Treatment of Acute Lung Injury Network. The overall study PIs were Nate Shapiro from Boston and Ivor Douglas from Denver. And the PEDAL Network, which is a large network that I'll explain in a little bit more detail, conducted the study. I'd like to give a quick shout out to really the people that actually did the work of this study, which is our amazing research staff. And in our Pacific Northwest site, we had a team of research coordinators screening for patients in this trial for many hours of the day and investing a lot of blood, sweat, and tears into completing this work. And so really the lifeblood of any clinical trial is the research staff. And so I wanted to make sure we acknowledge them. So the design of CLOVERS was a multi-center prospective phase 3 trial. It was non-blinded, as it's pretty difficult to blind clinicians to fluid volume. The intervention was the 24-hour fluid and vasopressor titration strategy that we'll talk about in some more detail. The primary trial endpoint was 90-day mortality prior to discharge home. The trial had planned to enroll just over 2,300 patients, which gave it a 90% power to detect a 4.5 absolute difference in the primary endpoint of 90-day mortality. And importantly, there were planned interim analyses done at the 1/3, 2/3, and final mark, and you'll see why that becomes important shortly. As I mentioned, this was conducted in the NHLBI PEDAL Network, which is a multidisciplinary network of acute care researchers in emergency and critical care in the US. There are 12 clinical hubs that serve as hubs to over 60 hospitals, which are essentially the spokes, and the clinical coordinating center is at Massachusetts General Hospital in Boston. The inclusion criteria for CLOVERS were that patients were adults. They had suspected or confirmed infection, which was defined as either administration or plan to administer antibiotics, and they had hypotension. And they had to have a systolic blood pressure less than 100 or a MAP less than 65 after at least 1 liter of fluid. They had to have a blood pressure below their known baseline. There were many exclusion criteria. I'm going to highlight just a couple. Probably the most challenging one is patients were excluded if greater than 4 hours elapsed since they met inclusion criteria. So we intended to enroll patients very early in the process. They were also excluded if they received greater than 3 liters of pre-randomization IV fluid. And they were excluded if they had any new signs of volume overload or pre-existing signs of volume overload. So patients allocated to the restrictive arm were treated according to this strategy. Initially, all IV fluids that were infusing were stopped. And then there was a plan for serial assessments every 30 to 60 minutes. If a patient had hypotension, vasopressors would be initiated, and we expressed a preference for norepinephrine as the first-line agent. And the second vasopressor was at the discretion of the treating clinician. And vasopressors would be titrated to meet those blood pressure goals. And then if patients met any of the criteria you see listed there for rescue fluid, they could receive rescue fluid boluses in 500 milliliter aliquots. And those were severe hypotension, rapidly escalating vasopressor requirement, persistent lactic acidosis, tachycardia, signs of extreme hypovolemia on echocardiogram, or suspected digital or bowel ischemia. So there were some criteria that allowed clinicians licensed to give fluid if they thought it was clinically appropriate. Patients allocated to the liberal arm immediately received 2 liters of fluid over 30 to 60 minutes, and vasopressors, if they were on board, were titrated down, and they had a similar reassessment strategy. And then if patients had met any of these criteria to administer more fluid, hypotension, low urine output, lactic acidosis, tachycardia, any objective measures indicating likelihood of fluid tolerance or responsiveness, they would get additional 500 milliliter fluid boluses. There were also criteria set aside for rescue vasopressor administration. So once a patient had received a total of 5 liters over the first 24 hours, clinicians could start vasopressors, or if they had any manifestations of fluid overload, and then some of the other features that you saw on the same rescue list for fluids. And again, preference for norepinephrine in the liberal arm as the first-line vasopressor. Partway through the study, in response to some concerns raised by an external group, we added an additional component to this arm of the protocol, which was after the first liter that patients received post-randomization, we included a clinical assessment, and if hemodynamics had normalized at that time, the patient didn't necessarily need to receive the second liter post-randomization. So that was added just as another layer of safety. I think a lot of this was happening already because research and clinical teams were watching these patients carefully, but we added it to the protocol. As I mentioned, the primary endpoint of the trial was all-cause mortality prior to hospital discharge before 90 days. There were a number of secondary clinical and care process endpoints. I'll highlight just a couple of them, including organ support free days, ventilator free days, renal replacement free days, change in SOFA score, and then some other process measures like the proportion of patients receiving central venous catheters or peripheral vasopressors. Well, many of you have probably read the trial by now, as it's been published for a couple of months, but the main results of the trial was that it was stopped for futility at the planned second interim analysis, which was at the 2/3 mark after just over 1,500 patients were enrolled. The enrollment period spanned from March of 2018 to January of 2022, which you'll note crossed a fairly important time period in critical care. And that contributed to some of the challenges within the trial, but the trial was actually able to enroll throughout the pandemic. This is the figure 1 patient flow diagram from the manuscript. Over 12,000 patients were screened for the trial. The main reasons for exclusion were greater than 4 hours elapsing since meeting inclusion criteria and greater than 3 liters of fluid administered. And the main reasons that patients were not enrolled from the trial were unable to obtain informed consent or a surrogate declined consent, and then the treating physician refused participation. These are the baseline characteristics, or table 1 from the study, and I just highlighted several of them. Patients were about 60 years old. There was a fairly even split of males and females. The trial predominantly included white patients, but there were about 15% overall Black patients included as well, and then a fair number of comorbidities, with diabetes being the most common, but we did include patients with heart failure and a handful of patients with end-stage renal disease. Those were not exclusion criteria, unless the patient was volume overloaded at the time of enrollment. Illness severity was moderate, I would say, with SOFA scores in the range of 3, systolic blood pressures around 90 on enrollment. We did manage to enroll patients fairly quickly. The time from eligibility to randomization was just about an hour, and a majority of patients were randomized in the ED. Importantly, this was not a trial of 30 cc's per kilo upfront for sepsis resuscitation. This was really a trial of subsequent resuscitation over the first 24 hours, and reflecting that patients got about 30 mLs per kilo of fluid resuscitation prior to randomization, so about 2 liters, obviously depending on their body size. When we look at total volume of fluid that patients received over various time points, as I mentioned, pre-randomization, patients got about 2 liters of fluid. That was even between the 2 arms. That 0 to 6 hour mark is really where we started to see separation between the groups, with the restrictive arm only receiving 500 milliliters, the liberal arm receiving 2,300. That persisted over the 0 to 24 hour mark, with the differences you see there, and the difference remained to be about 2 liters between the liberal and the restrictive arms. This is a different way to look at kind of the distribution and timing of fluid resuscitation. Most of the patients who were in the restrictive arm received all of their fluid volume very early and then received very little afterward. The liberal arm continued to receive fluid volumes later in their hospital course. This is the results from the primary endpoint. The mortality prior to discharge home by day 90 was statistically the same between the two groups at approximately 14%. You can see the completely overlapping Kaplan-Meier curve from the manuscript. There were a large number of subgroups that were analyzed. These were based on demographics and pre-existing medical conditions, as well as illness severity. And the punchline is that there were essentially no differences across all of these subgroups. There were some really interesting kind of process measures that were uncovered in the trial. First of all, in terms of just global resource utilization, patients in the liberal group were less likely to go to the ICU within 24 hours of admission and also within 7 days of hospitalization, and had about a 7% higher utilization of central venous catheters, implying that the restrictive strategy led to a bit more resource utilization than the liberal strategy. This also, I think, is one of the largest experiences to date of peripheral administration of vasopressors. Actually right on the dot, 500 patients in a study overall received vasopressors through a peripheral catheter between randomization and 72 hours, and there were very few complications, less than 1%. And those complications were all relatively mild, self-limited. And so I think this is an important finding from the trial that is going to be delved into a bit more. So some of my take homes from the trial. First, this was really a logistically challenging trial. When the trial started, there was concern that an early vasopressor strategy was not standard of care for sepsis, and that the perceptions of equipoise were that restrictive strategy arm did not reflect current sepsis care. By the end of the trial, the perceptions of equipoise had really shifted, and many more people were comfortable with the early vasopressor strategy than they were with the fluid liberal strategy. It was interesting to see that evolution over the approximate 10 years that this trial took from conception to completion. Obviously, this trial was conducted over the course of the COVID-19 pandemic, and that raised all sorts of logistical challenges. And I'll leave it at that. It was a tough trial to complete because of that reason. And then the structures for informed consent in the US really posed some challenges to this trial. I think all of us would have loved to see a trial of immediate fluid resuscitation. What do we do from the moment the patient hits the door? But the regulatory environment in the United States did not really prohibit that kind of a trial, because early consents from patients or legally authorized representatives was required for this trial. I think that resulted in several things. One is it probably resulted in us enrolling less severely ill patients than we would have liked to. And two is that some time had to elapse before patients were enrolled in the trial. And we and the entire committee that was involved with the trial design did not feel it was ethical to not provide fluid resuscitation during that time interval where consent was being obtained. I think some of the bright spots is that there is a huge amount of ancillary data, including biospecimen data for biomarker analysis and ancillary studies like the peripheral pressor study that will be completed with data from this trial. And I think we'll learn a lot from some of the ancillary work that's already planned and will be done in the future. And I think my overall clinical take home as a clinician is that this study really gives clinicians license to individualize their approach to fluid resuscitation based on what the patient needs and what that patient's individual physiology is, as really neither approach was better or worse at the population level in patients that were enrolled in this trial. I've presented kind of my personal algorithm for sepsis resuscitation at the Pacific Northwest Conference before, and I think I'll just come back to this because I think that this trial really gives us license to use something like this, acknowledging that the tools that we use to make some of these assessments are imperfect and really need further development. But for patients that were included in this trial, which were patients with infection and hypotension, the first question that I generally ask is volume tolerance likely? And I'll use a combination of just clinical history and exam, and potentially some higher tech tools like point of care ultrasound to help make that initial assessment. If so, as highlighted by our previous speaker, I think our default fluid for most patients should be balanced crystalloid, but there's some exceptions to that. And I'll give them a fluid bolus if I think they're likely to tolerate that fluid, and then reassess perfusion. If perfusion is still inadequate, I would start norepinephrine and continue to reassess whether perfusion, fluid responsiveness, and tolerance is adequate. And based on those assessments, give either additional fluid or add or increase vasoactives. And I operationalize this at the individual patient level, not necessarily at the population level. I think where we need to learn more is really how to accurately assess these things at the bedside and how to scale accurate assessment so that clinicians with various levels of expertise can have tools available to them to help them make these tough decisions. And I also think we probably need to understand a little bit more about the individual biology and specific patient phenotypes that might respond differentially to these different therapies. With that, I will stop, and I think we'll take questions at the end. Thank you all.
Thank you, Dr. Johnson. Our next speaker is going to be Melissa Parker. Melissa, Dr. Parker, do you want to take over?
I think you should be able to see that now.
Yes, we can.
Okay, great. Thank you for the opportunity to talk. And in speaking last, I was anticipating what some of the previous speakers were going to touch on. And so that's amazing context to now speak about the pediatric aspect of this. In terms of disclosures, I have no conflicts, but would like to note that I'm the PI of the SQUEEZE trial, which we'll talk a little bit about during this talk. So in terms of objectives, I thought I would start by talking a little bit about how we give fluid, because that's really how I wound up doing research in this particular area. And it is something that's maybe somewhat unique to pediatrics. It was interesting to hear the last speaker talk about the use of peripheral vasopressors, because that's actually something we've been doing in pediatrics for a very long time. We'll also talk about how much fluid, and then touch on what type of fluid, at least in terms of from the pediatric perspective. Context, I think much of this has been covered earlier in the forum, so I won't spend time dwelling on it, except to say we all know sepsis is a huge problem. It consumes a huge amount of resources, and there is lots of controversy about certain aspects of care. And in terms of the most recent pediatric update in the Surviving Sepsis campaign, that actually was published back in 2020. And we'll touch on some of those recommendations and how those line up with the evidence during this talk. So how do we give fluid? This is, I actually started in this area in terms of trying to improve knowledge translation at the bedside. You know, the guidelines when I started published by Brierly et al. Back in 2009, were saying I should be giving boluses of 20 mils per kilo over 5 minutes. And really, it was a practical question of how the heck do you do that? Talked a little bit to providers about how they actually achieve that at the bedside. And what we found out is that in pediatrics, we do some unusual things. Not only do we use things like the rapid infuser device and regular infusion pumps, but we also use syringes in interesting ways, not only using triple stopcock, but also just lining up syringes on the end of the bed to push fluid in sequence. And interestingly, the different techniques that providers would use were very much age dependent. So this is the push-pull method, which I think is used in both adults and pediatrics. It seems fairly straightforward, but in the middle of a crisis, people can get really hung up on toggling triple stopcock and sometimes pull blood out of the patient rather than pushing fluid in. So this is something that requires some practice. And then, as I said, there was really kind of observed at the bedside this very crude method of just having people pulling up fluid and lining up syringes on the end of the bed and just pushing them in as fast as possible. Not sophisticated, but commonly practiced. And so we actually started by studying this in terms of what syringe size do you use, how does this actually help you achieve rapid fluid resuscitation. And of course, if you're using 10 ml syringes, they're easier to push, but you have to change them out more frequently. And so we found that using 30 or 60 ml syringes was optimal in terms of actually fluid delivery. And then in terms of the push-pull technique, this is something that we found again in looking at this in a simulated setting was actually much more complicated in practice when we actually videotaped providers actually using this method. And so this disconnect reconnect technique, which again you would see people do at the bedside, was something that actually was fairly effective, but not really reported in the literature. So while studying that, as was noted by one of the previous speakers, there was a landmark publication that came out back in 2011 that really kind of turned this whole area on its head, and that was the FEAST trial published by Kath Maitland and their group, and this really just caused the whole field to just say, maybe we should just stop giving patients, fluid resuscitation because fluid is apparently killing people. And then there were related concerns in terms of, the external validity of those findings of a very high quality trial to contexts where children and adults were being resuscitated in environments with access to advanced critical care. And so how exactly, did the findings of the FEAST trial actually apply in our setting? And the results, as were covered by a previous speaker, that showed that essentially that fluid boluses were associated with increased risk of death and no difference between albumin and saline in the trial. So that led to the question of how much fluid, and it was really when I read this systematic review that came out in 2012 that I really got thinking about how would we actually study that in our context. And the findings of this was a South African group, and the findings of this systematic review, which was attempting to look at the evidence base, found that most of the evidence actually was coming from Asia, from Southeast Asia, Vietnam, India, looking at patient populations like dengue shock, again, in terms of thinking about applicability to our patient populations in countries like Canada, where I'm from. What did this actually mean? And so the most important conclusion from me from this study was really what's the applicability of the findings of the FEAST trial to populations in other settings. And as a clinician, I certainly couldn't reconcile giving no bolus to my patients, and I didn't think that any of my colleagues would be okay with that either. Remembering that this was back in 2012 that we were now thinking about this. So how actually would we study this in our clinical context? And that's really where the idea for the SQUEEZE trial came from. So SQUEEZE was actually funded back at the end of 2012, so quite a long time ago. So things moved more slowly in pediatrics than in the adult world, in part because it's harder for us to recruit patients, takes longer. So we'll come back to that, but I thought first off we would just touch on the most recent guidelines and what the current recommendations are, considering that this is now almost these came out almost 10 years after the FEAST trial. And in terms of settings where patients have access to advanced critical care, that the suggestion is still to administer up to 40 to 60 mils per kilo in bolus fluid over the first hour, titrated to clinical markers of cardiac output, and discontinued if there's clinical signs of fluid overload, but noting that that is a weak recommendation with low quality of evidence. And really, if you read the guidelines, you also note that they talk about fairly crude clinical assessments in terms of does the patient have crackles on auscultation? Is there any hepatomegaly? There's lots of different tools and clinical maneuvers we can do to attempt to get at whether there's adequate preload or what the intravascular volume status is. But this is actually an extremely complex thing to do in clinical practice, and even a separate area of investigation. So there's also some pediatric literature linking fluid overload to adverse outcomes. And as was mentioned also before, this is kind of a chicken or egg problem. Patients that are sicker get more fluid. And so does that mean that because they got more fluid, they have worse outcomes, or do they have worse outcomes because they in fact were sicker in the first place? So Dr. Al-Abaidi conducted a systematic review looking at the association between fluid balance and outcomes in critically ill children, and published that in JAMA Pediatrics several years ago. And so this nicely illustrates that in the vast majority of cases, that outcomes favored no fluid overload in terms of benefit to patients. So we know that fluid overload is bad. I don't think there's any question about that. The question is, how do we actually avoid that? And so we're really just left with this question of, fluid is good, we need it, but how much should we give? And, totem and taboo, that it's a good thing and a bad thing at the same time. So as I noticed, the SQUEEZE pilot actually started enrolling patients back in 2014. So the pilot trial enrolled between 2014 and 2016, and then we received major funding from CIHR to conduct the definitive trial, which was recently completed. And the research question in SQUEEZE, similar but not the same as Clover's, was investigating fluid sparing strategy to achieve ACCM therapeutic goals compared to the usual care of aggressive fluid resuscitation. The inclusion criteria were patients 1 month to 17 years of age. They had to have persistent signs of shock, suspected or confirmed septic shock. So that was based on the clinician's clinical diagnosis. And they had to have achieved a minimum fluid resuscitation threshold, again, getting back to the fact that we didn't think anyone would have any equipoise to randomize a patient to no bolus. So within the previous 6 hours, they had to have received 40 mils per kilo of IV or IO, isotonic crystalloid or colloid, or if they were 50 kilos or over, a minimum of 2 liters. And so they had to have all of these things essentially to meet the criteria for fluid refractory septic shock, at which point they could be enrolled in the trial. So SQUEEZE was actually approved for exception to informed consent or deferred consent, as is called some places. And so we were able to, once these patients were eligible, we were able to randomize them immediately and then sought consent after the fact at an appropriate time. And so this is really just, kind of usual care versus fluid sparing in terms of conceptualizing these two different resuscitation strategies. And in SQUEEZE, the intervention was not just limited to the first 24 hours, it actually was limited to the duration of time that the patient was in shock. So if the patient was in shock for 7 days, then the intervention was applied for 7 days. In fact, it actually remained in place for 24 hours following shock reversal, because we actually know that some of the patients that appear to have reversed shock, some of those patients wobble and wind up back requiring further resuscitation. So the intervention was actually of potentially of quite a long duration, and that was because we knew that while a lot of the fluid is given in the initial 24 to 48 hours of resuscitation, that for patients that were critically ill over extended periods of time, then the amount of fluid that they would receive in the latter part of resuscitation would be quite significant. And so the 2 tiers of the intervention related to the timing of initiation of vasoactive medications. with the second tier being related to how you then titrated those medications relative to fluid once you actually were on vasoactive medications. And so this was the algorithm that was used at the bedside. And so this is for a patient if they were enrolled into the fluid sparing arm, that tier 1, if they had not yet been started on vasoactive medications, then they were instructed verbally by phone at the time of randomization that they should start vasoactive medications immediately. They should avoid further fluid boluses. But there was an out, as you can see on the right, that obviously if somebody was mixing up the epinephrine or norepinephrine infusion and the patient was hypotensive, then it was clinically acceptable to give a small volume fluid bolus, or if their clinical assessment indicated the patient had intravascular hypovolemia. And we actually explicitly didn't tell them which vasoactive medication that they should start in, because that's a whole other area of investigation. And then in tier 2, again, they were asked to preferentially titrate their vasoactive medications to achieve the ACCM goal-directed targets. And if required, based on their assessment of intravascular volume status, if necessary, they could give a small volume fluid bolus, and they needed to document their reason for that. So the patient had shock, they met eligibility criteria, they got enrolled. The intervention phase was variable in duration based on the length of time the patient was in shock. Patient was approached for consent after the fact, and ultimately either shock was reversed or death occurred, or in some cases the patient landed on ECMO. Primary outcome, fortunately in pediatrics, most of our patients survive, and so mortality isn't really a feasible or appropriate outcome in most pediatric trials. And so we were really interested in the difference in time to shock reversal, which has administrative implications in terms of admission to ICU, length of duration of stay in ICU, and cost implications as well. They also looked at a number of other secondary outcomes, including things like organ dysfunction. Interestingly, also things like catheter placement, chest tube placement, abdominal compartment syndrome, and other complications related to either fluid or vasoactive medication use. We planned to enroll 400 participants, and we actually enrolled slightly more than that. The trial isn't published yet, but is coming soon, so you'll have to wait. I won't be able to share any results with you today. In terms of what type of fluid, there's actually a number of recommendations in the Surviving Sepsis Guideline on this topic for children, and as was noted by the first speaker, we really have moved away from using starches and gelatin. There's really no evidence for use of colloids over crystalloids, and that's a weak recommendation with moderate quality of evidence. And the suggestion to use balanced or buffered crystalloids versus normal saline is also based on a weak recommendation with low quality of evidence. And then the recommendations against use of starches or gelatin. This is a recent systematic review that looked at the impact of balanced fluids versus normal saline on outcomes like short-term outcomes like pH and serum bicarbonate. 13 articles were identified, only 3 of which were suitable for meta-analysis, and for children 1 month to 18 years of age. And the authors found that in terms of these biochemical short-term outcomes, there was a signal towards favoring balanced fluids, but really the clinical implications of that are unclear. And that really a randomized control trial is needed in this area as well. So prompt bolus is actually a very large RCT that's going on right now, comparing balanced versus unbalanced fluids in children with shock. And the PI for that is Fran Balmuth out of Children's Hospital of Philadelphia. And the question is whether in children 6 months to 18 years of age, does use of balanced fluids improve clinical outcomes compared to resuscitation with normal saline. Now, in this study, patients can receive the intervention fluids for a maximum of 48 hours. And the primary outcome is MAKE 30, which is a composite outcome of renal failure and death. This study is going to enroll, or is planned to enroll, over 8,000 patients. That is massive in pediatric terms. It's estimated to be completed in 2025. And the protocol is published here for those who are interested in reading about it a little bit more. There's 24 sites currently involved in Canada, in US, and ANZIX is involved as well. So in conclusion, fluid resuscitation and septic shock is a very complicated topic in both adults and pediatrics. There are many confounders. Current guidelines are based on weak evidence, but there are some RCT results that will be coming soon. So thank you very much for the opportunity to give this talk, and happy to answer any questions.
Thank you, Dr. Parker. So Dr. Delaney was not able to stay with us. It's in the middle of the night in Australia, so he needed to get some rest. My question, please put your questions in the question and answer section, and we will get our speakers to answer those. To both Dr. Parker and Dr. Johnson, when you're at the bedside, and I think, Nick, you answered a little bit about this, but you have someone who is in septic shock, what fluid are you going to pull out and use, and how much are you going to give to the adult and the pediatric? I feel like what I heard Dr. Delaney say, and this is what I heard, so I don't want to totally quote, was he starts with giving a balanced crystalloid, and then after reaching that 30 mils per kg moves to albumin. So what are your thoughts? What's your approach?
I can go first. So I think in terms of the right fluid for all patients, I don't know that we have that answer entirely. But I think when you're thinking about like the bedside cart that has bags of fluid in it, the top of the cart should have LR. I think for us, at least, it's the most cost-effective balanced crystalloid that exists. There are some others that perhaps have a composition that look more like plasma, but are a little bit more expensive. And so I think that's a reasonable default. I think there are some interesting subgroups of patients, like brain injured patients or those with hypochloremic metabolic alkalosis from vomiting, who might benefit from other fluids. But the default for a majority of the patients that I take care of with sepsis is going to be lactated ringers. In terms of volume, I don't think that there's a single right answer, honestly, and I know that's hard, but I really think we probably are going to need to move away from this one-size-fits-all fluid resuscitation approach to a more individual-based approach. I think that Clover's and some of the other studies have shown us that we're probably not going to make a huge difference, at least in patients at the illness severity that were enrolled in that trial, with one strategy over another. But I think at the individual patient level, there are some patients who are going to be harmed by more fluid. And there are some patients, at least from a resource utilization perspective, who otherwise could have avoided vasopressors and potentially an ICU stay and potentially a central line if they get less vigorous fluid resuscitation. And I think that decision has to be made by the clinician at the bedside, looking at that patient and weighing those risks and balances, which is we all want an algorithm that we can just apply to every patient. I just don't think it exists.
Thank you. Dr. Parker, what's your approach with your pediatric septic shock patient in front of you?
I still have equipoise on a lot of these issues. I mean, to be perfectly honest, I mean, sometimes it's just the practical question of what's in the room and what's most readily available. So if it's normal saline, I'll go with normal saline. If there's lactated ringers there, I'll use that. I would say certainly, though, once you start getting into the situation where you're beyond the initial 40 to 60 mils per kilo of fluid, then we know that hyperchloremia is associated with acute kidney injury. And so I think that for those of us that will still give normal saline during the initial phases of resuscitation, I think we'll then subsequently move to lactated ringers to try and avoid the hyperchloremia and the hyperchloremic acidosis, which we know is a problem. So personally, I don't have a problem giving normal saline. I don't think the evidence shows that we shouldn't give it, but I think that giving a lot of it is a problem in terms of the hyperchloremia.
And then with the pediatric population, are you using vasopressors peripherally?
I would say that we've been ahead of the pack doing that often for practical reasons. I mean, if you've got a little 9-month-old in the emergency department, nobody's just popping in a central line to that patient or a moving toddler. So really, practically speaking, I mean, intraosseous if for initial resuscitation, but quite frequently we will run peripheral vasoactive medications. And the other thing about children is they have an amazing capacity for recovery. So I would say it's not rare for us to actually admit a child with septic shock to the ICU. And if they're on a little bit of norepinephrine, or in our case, sometimes epinephrine, and if we find the patient stabilizing out, then sometimes we actually can spare that patient invasive and painful procedures by just watching them with a little bit of vasoactive medications. And so I think that you'll find that a lot of clinicians are actually just using their clinical judgment in terms of the trajectory of the patient. And sometimes some of those patients will come, not get an ART line, not get a central line, and they'll be on maybe some peripheral norepi for several hours, and then they'll stabilize out and they'll get kicked out of the ICU the next day. And I think that rarely happens with adults, but I think we've been using peripheral vasoactive medications in pediatrics, certainly ever since I started training, which is a long time ago now. So I think that there's certain areas that we've been ahead of the pack in pediatrics, and other areas where we're clearly behind or have trouble keeping up in terms of evidence generation, just because it's harder for us to enroll. The numbers are smaller with recruitment. And but again, FEAST, that was a pediatric trial really that kind of brought to the forefront the whole question about really how much fluid should we be giving to children. So I think there are HFO oscillation. That's another area that came out of pediatrics. So areas where we're ahead, and then other areas where I think we're very much behind.
Thank you. Nick, can you speak to how you use peripheral pressors, and do you limit the amount or the length of time that you're comfortable using them?
Yeah, I definitely do. And I agree. This is something that I first learned from my pediatric colleagues. I was a resident at University of Pennsylvania in emergency medicine. And at the time, put in a whole lot of central lines for all sorts of doses of vasopressors, even very low on the adult side. And then I would go over to our neighboring hospital where I did some pediatrics training at Children's Hospital of Philadelphia, and learned that wasn't the practice there, even at that time. And that was the first time my eyes were sort of open to this concept. And when I switched institutions, I would say it was much more widely accepted that in adults, vasopressors could be run through a peripheral line. And whenever I see kind of inter-institutional variability, it implies to me that there's some opportunity to investigate that further. And I think the science on the adult side really lagged behind. And I think this was largely based on dogma that these, extravasation events would be devastating and limb threatening and not tolerable to patients and families, when really that probably doesn't have to happen very often, and that there are some treatment options that are available. And so there have been a couple observational studies in adults that have come out that have changed my practice over the past 7 or 8 years. And I widely use peripheral vasopressors now, usually relatively low doses, and usually for some time limited period that we don't have a hard limit. But I generally start thinking about whether this is the right strategy if I'm exceeding, 0.2 mics per kilo per minute equivalent of norepinephrine or more, or we're hitting the 24-hour mark and not making forward progress, like not down titrating the pressors. But I think hospitals should really look at these policies and really look at their own, extravasation events. And if there aren't many of them or any of them, rethink about whether this should be a strict policy or whether some guidance should exist around safe use of peripheral vasopressors, because I think this is something that a lot of us have already incorporated into our practice, and I think the data from Clover supports it.
I think that they're definitely, I feel very safe in using peripheral pressors up to a certain amount in the adult population. I don't know the pediatric population at all, but I will tell you, like, when you go to the literature, and I can see why hospitals get a little bit of heartburn with it, because when you go to literature and you see the extravasation events, when they do happen, they are pretty horrible. So I can appreciate the hesitancy as well. One question that we had for Dr. Parker was around albumin, and we heard Dr. Delaney speak on using it in adults, but in kids, there seems to be a signal for harm. Can you speak to why the difference?
No, I can't. I think part of the difficulty within pediatrics is the numbers are really small. And that really limits interpretation. I mean, I think, you know, kids aren't little adults. Could there be physiologically different impacts in terms of being advantageous in one population and not in another? I suppose that's possible, but you know, at least in terms of you know, the surviving sepsis guidelines, there's no, actually the recommendation is that, you know, really albumin is, and I appreciate that wasn't the case in Dr. Delaney's setting, but it's more costly and resource limited. And there's no clear advantage to using albumin. So I would say that really we're not using it unless we're finding that really severe hypoalbuminemia is causing major problems with oncotic pressure. And even then, you recognize that in giving it, it's potentially just going to leak out of the vasculature anyways. And so to what extent it's going to solve that problem. And then that's further complicated if the patient's got acute kidney injury in terms of fluid shifts and to what degree they can tolerate that from a cardiopulmonary perspective. So I'm not answering your question because I don't know the answer.
Fair enough. Good. And another question that came in is, with all the information that is come out on fluids in sepsis, is it safe to not give any fluids or just a small, very small amount? What do you guys think about that?
Maybe I can address that first, because I have to say, as an intensivist and someone who's been studying in this area, that's also juxtaposed with clinical experience. And I think a lot of us right now are managing some incredibly sick patients with invasive group A strep. And I can tell you, I've had personal experience that the patient is just massively extravasating, and the only thing they respond to is volume loading of massive amounts of fluid. So it's I agree with Dr. Johnson that I think at the end of the day, what we may learn is just really, you know, population level recommendations that this really needs to be more personalized medicine in terms of managing the physiology of the patient that's in front of you. I just think that there are certain patients that you just can't manage without giving those patients fluid because they just don't have the preload. I'm interested to hear what Dr. Johnson has to say.
Yeah, I agree with the sort of it depends approach on this. I think that you know, I work in two settings. I work in an ICU and I work in the emergency department. I think it's pretty rare in the ED to see a patient that with septic shock that is not volume depleted on arrival. I think even if people have not had overt volume losses, they have some capillary leak and they have some poor intake from days prior from feeling poorly, and usually in the ED come in at least somewhat volume down. And I think in that setting, it's pretty uncommon to see both concomitant volume overload and septic shock. It does happen with people with chronic medical conditions that predispose them to volume overload. So I'd say in that circumstance, when someone's already volume overloaded, it's reasonable to start vasopressors on the earlier side and then decide if additional fluids are going to give physiologic benefit. I think in the ICU, where I take care of post-surgical patients and other folks who develop sepsis later in their hospital course, volume overload and concomitant sepsis is really common. And in that context, I start vasopressors early on some patients with more frequency, and it really just depends on what their underlying shock physiology is and what my assessment of their overall likelihood of volume tolerance and responsiveness is going to be. And so I think this is another situation where you really have to individualize it. I'd say most patients I give some amount of volume to before I start pressors or around the time I'm starting pressors, but there are those those special patients who are massively volume overloaded and have very low likelihood of tolerating additional volume, where I'll just start pressors early.
Yeah, and just maybe just one final comment is that just you can't overemphasize the importance of frequent clinical reassessment of these patients from a cardiopulmonary perspective, hepatojugular reflex, all of these things. I mean, POCUS, POCUS is kind of falling out of favor a little bit. And I know when it kind of early on, we had concerns in pediatrics. I mean, looking at IVC collapsibility and, again, a 9-month-old versus a 6-year-old versus a 12-year-old, these aren't standardized measurements in children. And then again, how good is your diagnostic test? So the sorting out actually to what extent your patient is going to be fluid responsive is a really complicated area.
So I guess my question to you is, if you don't have fancy equipment, how are you determining if they need more fluid? What is your go-to assessment tool that you're using?
I think for upward, I'm not going to be scientific about this. For upward of 80% of patients, you can use just history and exam, right? Like I'll give you 2 patient phenotypes. 22-year-old who comes in with pyelonephritis to the ED, who's been feeling unwell for 3 days, maybe having some vomiting. Like they're going to be, I'm not even going to think more about that patient in terms of like, are they likely going to be tolerant or volume responsive? I'm probably going to give them a couple liters of fluid up front before I start vasopressors. They have a very high likelihood of tolerating that fluid if they have no underlying medical conditions and aren't volume overloaded. And the clinical context tells me that this is likely a state where volume responsiveness is super likely. Different patient scenario, 75-year-old with end-stage renal disease and ischemic cardiomyopathy with an ejection fraction of 10%. This was a patient I saw last night in the ED when I was working. That's a patient where I'm going to spend a lot of time thinking about whether fluid resuscitation is appropriate, what volume I'm going to give. I'm going to give small aliquots and reassess frequently. And so I think the overall clinical context really tells you a lot and informs the overall strategy. And I think this comes from clinical experience, which is something that just builds over time. I think in that patient, the one at very high risk for volume overload, thinking about using multiple tools to help you make these decisions, because every single one of these tools has flaws and limitations and false positives. And I think, IVC is a great example, in a patient with an ejection fraction of 10% and tricuspid regurg is going to be like a useless test. And so I don't think you can use that tool as a single data point in any patient. In fact, I don't know if you can use any tool as a single data point in any patient. So I think most of what you can derive is from the real basic like history and physical exam and what you know about the patient. And then the fancy tools get layered on top of that when you have access to them. But sometimes you just have to make a small clinical decision and then reassess the result and see if the patient got better or worse.
Yeah, and I would just say I like to think about where am I sitting on the Frank-Starling curve, and getting back to your initial fluid boluses, or at least in my case, would still be 20 mils per kilo. But once you're starting to get up over that, 40 to 60 mils per kilo, or if I'm starting to get concerned, again, depending on what kind of patient I'm dealing with, maybe I just give 5 mils per kilo. And I look at the heart rate response, I look at the blood pressure response, and I decide where I am on the Frank-Starling curve. And I agree. I think using multiple modalities to make your clinical decision is really, and the trajectory, just multiple data points.
In the Q&A, there is a question from asking specifically about passive leg raise, and what do you find that useful or not, and what are the limitations?
I think it's one physical assessment, just like hepatojugular reflex. And yes, I mean, sometimes practically there can be difficulties with doing that. If your patient's prone, if your patient's prone, you also can't do a hepatojugular reflex. But yes, I mean, that would be one of the maneuvers that you could do to try and assess where you think the patient is on the Frank-Starling curve.
Great, thank you. And then there's some, I hope you're seeing some of the things in the chat. Nick, there was one question you answered in the chat. I wanted to ask, give you a chance to answer it live so people actually heard your response. The question was, why do you think with there's such a negative benefit with fluids during COVID. And can you answer that question?
Yeah, I think was a good question from Rick, and I think the pandemic was sort of a little bit of an opportunity for us to see a relatively more homogeneous flavor of sepsis and ARDS, which was essentially viral pneumonitis leading to those things, with occasional superimposed bacterial infections. And I think the primary insult for most of these patients was viral pneumonitis, and perhaps with some vasculopathy related to the virus itself. And anytime you're resuscitating somebody with septic shock, there's this battle that's occurring. You're trying to maintain and augment cardiac output and organ perfusion and renal perfusion, brain perfusion, and not destroy the lungs. And in COVID, the lungs usually won or lost. And so we saw a lot of adverse consequences from fluid resuscitation, and generally we're a little bit more careful. I think, like with most things, we might have overcorrected early on in the pandemic and really there wasn't a lot of data at the time guiding these decisions, and a lot of the dogma was like, run these patients super dry. And we saw a fair bit of acute kidney injury, and I think maybe shifted too far toward a very dry resuscitation approach. And I think by the time we got more experience managing COVID-19, kind of ended up somewhere in the middle in a lot of areas. But I think it just highlights that sepsis and ARDS, they're not one disease. They're clinical syndromes that are extremely heterogeneous, and different subtypes of patients are going to respond differently. And I think the average COVID patient with bad ARDS and a little bit of hemodynamic instability tended to do better with a drier resuscitation strategy than perhaps other patients with bacterial sepsis.
Thank you. And Dr. Parker, did you want to comment about what the pediatric population and COVID, if you saw the same impact with fluids?
I mean, the pediatric population was relatively spared from COVID, to be honest. But I mean, if I can just offer something else, I mean, what I can't help but reflect on, and I've had this conversation with other research colleagues, is as a researcher, it drives you nuts when the pendulum is swinging, right? I mean, one day fluids are good, the other day fluids are bad, one day vasopressors are good, then they're bad. So how on earth are you supposed to do high quality research when, on the one hand, people are shifting their practice in the absence of evidence, and yet at the same time, we're having the discussion today talking about the fact that patients themselves are heterogeneous. So I think there are a lot of challenges to doing high quality research on these types of questions. And I mean, one of my colleagues who studies vasopressors said, I wish I could just take the clinician out of the equation and just basically have, have the computer basically titrate the vasopressors based on the parameters that I set. So because really, it's clinical judgment is sometimes flawed. But at the end of the day, we're also talking about how important that is. So there's a lot of irreconcilable differences, shall we say, in terms of trying to land on optimal management of these patients.
Thank you both. I want to encourage the audience to please put any questions you have in the chat for Dr. Delaney, and we will get them to him. And I'm going to turn this back over to David. I do appreciate Dr. Johnson and Dr. Parker's presentation today. Thank you so much.
Yeah, I would echo Mary Jo. Thank you for moderating such a great session. And what our attendees maybe don't know is there's a whole team of people sorting through questions. And so you did an amazing job of we were hammering you with a ton of questions because this is a passionate topic. And Dr. Parker, maybe next year at the Sepsis Forum, you can talk about AI and vasopressor titration. I think I heard you allude to that maybe. So maybe the computer will be better than us humans at vasopressor titration. Team, it has just turned sunny here in Seattle. The fog has lifted, and so I need an outside break. And so I would vote that we all take an outside break. Remember Shinrin Yuku, or the idea of forest bathing. This exposing yourself to nature is important. And so take a 30-ish minute lunch. Please go outside, please stretch your legs, please move your chi. And we will see you back at 12:30 for a great discussion about sepsis survivorship, both from newborns to adults, with Drs. Lisa Holste and Mark Mickelson. Thanks again, and see you soon.